And it's my pleasure now, if Susanna wants to share her screen, to introduce Associate Professor Susanna Park, who leads a research group at the Brain and Mind Centre, University of Sydney. She's an associate professor in neuroscience, and her work focuses on investigating assessment strategies, treatments, and risk factors in neuropathy, with a focus on neuropathy following cancer treatments. And I'm delighted to ask her to present a talk today on understanding treatment-induced peripheral neuropathy and blood cancer. Thank you, Susanna.
Thank you so much, Tracy, for inviting me here to speak today. So today I'm going to talk a little bit about peripheral neuropathy and peripheral nerves. So basically, peripheral nerves, their job is to convey messages between your brain and spinal cord and the rest of your body. And so they're really important for carrying sensory and motor information to and from the nervous system. And they're also involved in regulating involuntary body functions. So if there is damage to the nerves in the peripheral nervous system, and that's what we call peripheral neuropathy. And when there is damage to these nerves, the messages that they pass between the brain and spinal cord and the rest of the body are disrupted, a little bit like static on an old telephone line. And it's really important that these messages can be passed across these nerves, because nerves, as you can see here on this diagram with the peripheral nerves in blue, are very long. And so it's important that the messages that they send, so sensory information about touch and pain and motor information about how to move your muscles, it's important that this information is faithfully transmitted for the body to work properly. So there's lots of different causes of peripheral neuropathy, things like diabetes, genetic mutations, vitamin deficiencies. Today, we're going to be talking about the effect of medications on the peripheral nervous system. And so this is a partial list of medications and toxins that have been known to cause peripheral neuropathy. And you can see that it's quite a lengthy list. And all of the drugs that are underlined here in red are actually used in the treatment of cancer. So there's a lot of different types of medications that are used in cancer treatment that can cause peripheral neuropathy. And these drugs are used to treat a whole variety of cancers. So in addition to blood cancers, drugs that are used to treat colorectal cancer, breast cancer, ovarian and lung cancers can also cause peripheral neuropathy. And these are the main drug classes that are associated with peripheral neuropathy. Platinum-based drugs, taxane drugs, and a whole range of drugs that are commonly used in the treatment of blood cancers, such as bortezomib, vinca alkaloids, and thalidomide. And so in terms of the most commonly used agents for the treatment of blood cancer that can cause neuropathy, the proteasome inhibitors, particularly bortezomib, thalidomide can also cause neuropathy, and vinca alkaloids such as vincristine are also associated with neuropathy. And newer agents such as the antibody drug conjugates have also been demonstrated to show peripheral neuropathy in trials, as well as less commonly used agents such as platinum-based drugs. In terms of the key symptoms of peripheral neuropathy, the main symptoms are sensory and things like tingling, numbness, discomfort, and pain. And typically these symptoms arise in the hands and feet and are broadly symmetrical. And they cause functional problems with balance, difficulties using your hands, doing up buttons and other fine motor tasks. And this is one of the important functional aspects of sensory neuropathy, that it can cause this effect on sensory motor function. And so in total, we need more research into the best way to assess this toxicity, how to prevent it, and ultimately how to treat and manage peripheral neuropathy. And that's what some of our research has been aiming to do. So I'm going to present on a survey that we did of 986 Australian cancer survivors that were treated with these neurotoxic drugs. So 77% were reporting current neuropathy symptoms, and this group were about 3.5 years post-treatment. They were primarily treated for solid tumors, but there were also some multiple myeloma and other blood cancer patients in the cohort. And so as what we found when we looked at this large cohort was that the patients that reported severe neuropathy shown here in the blue, they reported worse quality of life compared to the patients that had lower level neuropathy. They reported higher levels of overall pain, as well as burning or neuropathic pain. And they were more likely to have a higher body mass index, and they were more likely to have received multiple different neurotoxic chemotherapies. And so this underscores, I guess, the impact of these drugs on the peripheral nervous system. And so we also looked more in depth at our respondents with multiple myeloma. And so we had 108 patients in our study. The majority of them had received both bortezomib and thalidomide, and they were surveyed at almost 2 years post-completion of their neurotoxic treatment. So 82% of the myeloma patients reported at least one neuropathy symptom that bothered them quite a bit or very much, illustrating the burden of symptoms in this cohort. And there were also patients who had difficulties with functional tasks such as walking and fine motor skills. 35% of the patients in our study reported burning pain. And there are some, for some patients, there are therapies that can address the painful aspect of neuropathy, sometimes more effectively than other symptoms such as tingling and numbness. So that's an important thing to note in this cohort. So I guess looking at the impact of peripheral neuropathy in this patient group, we really wanted to know what is the best way to assess it. And there's actually quite a bit of a gap in terms of ideal assessment tools, and there's no gold standard. So in different studies and in different groups, the way neuropathy assessed varies a lot. And so for that reason, we set up our study, which has been a really fantastic collaborative study across lots of different sites and with lots of different types of researchers and clinicians, and also including Tracy King and the colleagues here at the Sydney Blood Cancer Research Group. And so we were trying to look at what the best type of assessment tool was. So we used a whole range of different types of assessment tools to try to look at this. And today I'm just going to be talking a bit about the assessment of balance and how we can quantify the potential balance impact of neuropathy in patients treated with neurotoxic chemotherapy. And so this shows how we quantify balance and functional impairment. So you can see there is this little metal tail that is attached, and there's a stylus on it. And you can see that the movements that the person makes are then translated via the stylus onto the iPad. And this is called postural sway, and it basically collects how much your body is moving as a surrogate marker of your balance. And so when we do this task and we attach this sway meter bar to the person, we do different kinds of conditions. So in one condition, someone is just standing there, then we get them to close their eyes. So in people with neuropathy, they use they use their visual system to try to counteract the effect of loss of sensation. And so closing the eyes makes it more difficult to balance. And then we also introduce, you can see this foam block to make it even more difficult to balance. And so this will give us, by measuring the amount of sway, we can quantify the balance. And so in our study, we looked at 190 people who were treated with different neurotoxic cancer treatments. The majority of these were treated with paclitaxel or oxaliplatin, but we did also have some patients treated for blood cancers in this cohort. And in the cohort that we had, 68% of them were reporting symptoms of peripheral neuropathy. And what we found when we looked at this sway, you can see here the postural sway sum score, and that's basically just how much movement was there when you're trying to stand still, how much of this balance variation. We found that people who had worse neuropathy had worse balance performance. And so you can see that it was associated with both clinically graded neuropathy as well as patient reports. So when people reported greater symptoms, they had worse balance. And this was also linked to functional disability. So people with worse balance were also reporting more impact of neuropathy on their daily life. And we actually found that the balance performance of our group that had been treated with neurotoxic cancer treatments, they were actually performing similar to a much older cohort who were at risk of falls. So the researchers that we worked with had also done studies in older people to look at falls risk. And we found that the people treated with neurotoxic cancer treatments were actually performing at least 10 years higher than their actual age, so much like an older cohort. This is suggesting that in some patients treated with these drugs, there's a big impact on balance. And other studies have shown that there may also be an increased falls risk from peripheral neuropathy as well. So I guess based on these results, we wanted to see if there might be an intervention that we could do to intervene in this specific effect of neuropathy on balance function. And so we did a small study looking at the effect of balance and exercise training in people treated with neurotoxic drugs. And so this was in 26 patients who were more than 3 months post completion of their neurotoxic treatment. And so first there was an 8-week waiting period, which was the control period. And then there was an 8-week exercise and balance training period. And so that was 3 times a week exercise sessions with an exercise physiologist. And this was, I guess, tailored to the individual, but also had a component of training the balance to see if that could improve. And as what we found was people reported less symptoms. So here you can see the 8-week control period where patients were not having the intervention, followed by the 8-week intervention period. And the patient-reported neuropathy scores decreased, so people noticed less impact of their symptoms. And we also found that the neurologically graded neuropathy decreased as well in that 8-week exercise period. And we also found a whole range of other improvements. So that balance that I was showing you on the sway meter, that also improved over the 8-week training period. So this demonstrated that a targeted balance and exercise intervention might be able to improve the functional disability experienced by patients with peripheral neuropathy. And so on the basis of this, we're currently undertaking a larger randomized controlled trial across 4 hospitals in Sydney to look at this 8-week intervention and also compare it to a home program to see if we can improve neuropathy symptoms and balance function in a larger cohort of patients. And so in this trial, we've got a number of different outcome measures to try to really measure these functional deficits in neuropathy. And so a lot of the time when people describe the impact on their balance in walking, rather than having falls, they'll say that they just need to be extremely vigilant, they use their eyes a lot, or they're very worried about falls, so they modify their behavior to reduce their risk. And so to try to pick up these elements in conjunction with some researchers at Neuroscience Research Australia, we've designed some different outcome measures to try to focus on these functional elements of neuropathy. So the first one is just a simple walk, just walking for 15 meters. And then in the second task, the participants have to walk while completing, so basically subtracting from a 3-digit number by 7. And it's not really, this is usually quite horrifying to people to have to do maths while they walk. I certainly didn't enjoy it, but the main point is to use your brain so you can't focus on your walking. And that sort of can demonstrate some of the deficits that patients have. So if they're trying to do 2 things at once and they can't focus on the task, then they'll demonstrate more deficits. Similar to that, we have a choice stepping reaction map, and this is where the screen will demonstrate where participants have to step. And in some conditions, there's a purple color arrow, and then you need to not step. So again, it's looking at your reaction time and your performance when there's a cognitive task. So deciding not to step or to step. And then this may also demonstrate added effects in people with neuropathy who need to, I guess, think more about their movements because of the lack of sensory feedback. And finally, we have a coordinated stability task where there's the sway meter is used in front with a red pen, and people have to follow this pathway without trying to get outside the lines. And so this task will also try to bring in, I guess, the kind of more complex issues with their movement that people with peripheral neuropathy can experience. And so we're hoping that using these kind of outcome measures, we'll be able to really quantify the deficits that patients are telling that they have, and to really demonstrate if this kind of intervention can help improve these aspects of patients' life. And ultimately, we're trying to incorporate these elements into a clinical pathway, which also includes our work on assessment of toxicity, as well as other management guidelines to, I guess, standardize the way that peripheral neuropathy following cancer treatment is assessed and treated. And so just briefly, this is the pathway that we've developed in conjunction with 70 multidisciplinary oncology, hematology, neurology, and allied health professionals. We focus on pre-treatment assessment, patient education, and screening. And then during treatment, we focus on the identification and management of functional deficits that we were just talking about in terms of balance and risk of falls, and also management of pain, and referring to services as appropriate to have a coordinated response to peripheral neuropathy. And the next steps for this are screening this pathway and hopefully implementing our improved screening, which is currently operating at 2 hospitals, but trying to implement that more widely to identify neuropathy earlier and to be able to follow best practice in assessment and management. So thank you very much. Basically, hopefully I've demonstrated the potential impact of novel assessment tools in looking at functional disability and neuropathy, as well as the potential role of exercise rehabilitation. And there's been a huge team that have been helping with this research. So thank you to all of you, and also thank you to all of the patients who've participated in these studies. Your involvement has been essential and fantastic. And also thank you to Tracy and team as well.
Thank you. Thank you so much, Professor Park. That was a great whirlwind stop tour of what is, I know, a very large body of work that you and your team have been doing. We do have one question that's come in. I'm not sure if you're best to answer that, or perhaps one of the hematologists, but somebody has asked, does myeloma itself cause nerve damage and neuropathy in addition to the drugs? Susanna.
Yes, so myeloma can be associated with neuropathy, and particularly neuropathy can be caused by excess paraprotein. I think the exact prevalence, I guess, is not clear, but I think in large cohort studies, they could say between sort of, 25%, around 25% of patients might have this, but I guess it would also depend on staging and other clinical factors.
Right, lovely. And final question, the study you were talking about, it's so nice to see an intervention, something that can actually make a difference for patients in terms of these symptoms. Is the study with the exercise, is that available at the Lifehouse?
Yes, yeah. That's right. We're running that at Lifehouse, as well as in Randwick and St. George and the Mater in the north as well.
Great, fantastic. Fantastic. Thank you so much. I think in the essence of time, we may continue, but I'm sure a lot of our patients will be seeing you and your colleagues as they participate in your ongoing research and work, Susanna. So thank you so much for your time today. Thank you.